We also have Elinore, who was introduced earlier, and Tarun Dua, the colleague from WHO who's joined. So we have the panel here. A wealth of experience from various parts of the world and from in various different expertise. So it's my pleasure to ask Graham the first question to you, because you chaired the expert group which reviewed the scientific evidence and developed the WHO guidelines. And as Tarun has explained, the strength of the evidence was good in some cases, but not so good in other cases. What were the big disappointments that you faced when you reviewed the evidence in this area? And would you have any suggestions as to how to improve that?
Thank you, Shekhar, and good morning, ladies and gentlemen. First of all, I'm not at all disappointed. I'm inspired by these guidelines. And I'd like also to add my thanks to Fountain House and also WHO for the leadership of this very important piece of work. So I began to sort of become aware of these issues. I've been working in psychiatry for 30 years. Only about 7 years ago did I actually sort of pay attention. And I was asked to comment upon a paper from several European countries, Scandinavian countries, looking at a 20-year gap. And I wrote a leader, British Journal of Psychiatry, and I said, this is a scandal. And I think it is. And then I was asked a couple of years later to comment on another study, this one from Australia, by Lawrence and co. And I thought, this really will not do. So I wrote a leader for the British Medical Journal. I said, this is fatal discrimination. And the journal said, ooh, careful, careful. These are strong words. We shouldn't overstate it. I said, no, I'm not overstating it. This is fatal discrimination. This really will not do. So I then began to see this as a form of structural or systemic discrimination. And I think that's what it is. I also want to add to what Tarun said about thanking the people who worked on these guidelines. And the core team, I just mentioned a couple of names because it was so much hard work. So that's Petra Gronholm, who's here, my colleague Maya Zemrau from King's, tremendous effort from the central WHO team with Tarun, with Neerja Chowdhury, and with Shekhar. Also Jay Das Munshi from my own university, and Corrado Barbui from Verona, and Kalitha Kalopa from Harvard. So this is just a great collective effort. Now, to come on to your question. So what we've got is 19 recommendations. 10 are made with the strong or the top strength of recommendation, and 9 are conditional, which means there's good evidence, but not as strong. And then you look at the base level of the evidence upon which we've made these recommendations. So we found that the evidence for 3 of these was moderately strong, 9 was low, and 10 was very low. Is that disappointing? No, that's par for the course. Why? Well, several reasons come together. One is that we've got low investment in mental health resource compared with all the physical health sectors. Secondly, although 85% of the world's population live in low and middle-income countries, at least 85% of the evidence is from the high-income countries. So there's that huge inverse care law in where the evidence is from. But also, there's a structural thing about whether a cardiovascular institute will pay for this research, or will it be a diabetes institute? The answer is not usually. And will institutes come together to look at comorbidities? They're only just beginning to look at that conjoint approach to these vital issues. Now, I remember clearly, a couple of years ago, I came back from Geneva. I was at a WHO meeting. It was great. I had a bag full of big, heavy reports. And at the airport, I picked up, and my back went. And in fact, I had to lie down for several days. So I went onto the internet, I looked at the best available evidence for low back pain, and it said, there's a team led in Norway doing exactly that. I thought, great, what's the evidence? And it said, systematic review is in progress. And I couldn't actually get good quality data on one of the most common physical disorders, low back pain. And that's common across the whole field. And even in areas which have been best funded and best research, HIV, still we could only find moderately strong evidence in the areas of target in this particular evidence. So what do? Do we do nothing? Of course not. That would be a counsel of despair. We make recommendations upon the best available evidence is what we've got. And to come on to your second question, then we actually really have to invest to do a better job of getting the evidence, especially evidence relevant to low and middle income countries, especially evidence about how these conditions affect the lived experience of people with mental health problems, because there's almost no usable evidence for these comorbid conditions about consumer experience as well. So often in global mental health discussions, I'm talking about stigma and discrimination. In fact, we'll say more about this afternoon at 4 o'clock in parallel session number 2. Increasingly, we're talking about stigma and discrimination as a question of social inclusion or social exclusion. Well, this issue is so important because it's not social inclusion, it's inclusion in life. And that's why I think these guidelines are potentially so important if we can actually implement them. Thank you.
Thank you very much, Graham, for being competent, being optimistic, and having a good plan as to what needs to be done. Thank you. We have Prabhakar from India, who has, as a part of the work in India and many other countries, has been trying to scale up services for chronic disorders and also for mental health. Prabhakar, will the presence of WHO guidelines change the way you do capacity building in India and other countries?
Thank you, Dr. Saxena, and a very good morning to everyone. I think before I answer that question, I need to provide the context of what you said about scaling up of training program across India and the world. When we look at undergraduate programs in medicine, there's hardly anything on chronic diseases, and even much less on mental health. And therefore, when people pass out, they become deficient in the management of chronic disease. And therefore, we decided that some kind of structured training program needs to be provided to primary care physicians. And because primary care physicians are the backbone of chronic disease management, they're needed for the referral system. Ultimately, they refer the patients to the specialist. But we thought some of the tasks of the specialists need to be shifted to the primary care physicians and further down to the nurses and to community health workers. Otherwise, we're not going to address even part of the problem of chronic diseases. So, you can't hear? Okay.
Can you speak a little bit up?
Is it on?
It's on. Okay. Oh, maybe it needs to be closer. Okay. So we decided that we needed a scaled-up program. So what we do is we have a knowledge partner who develops the course material, and this is vetted by experts. For example, within India, in diabetes, we will have 15 experts who vet the course, and then we train regional experts who deliver these courses on a designated Sunday, because that's a day when primary care physicians are available. They're otherwise very busy on other days. So one designated day a month, this modular course is delivered, or say 8 months, 10 months, 12 months, depending on the duration of the course. Now, this has become very popular, and in the last 7 or 8 years, we have trained almost 25,000 primary care physicians all across India. And this course has been taken by several state governments for their national programs, and it's being implemented. It's also being implemented across the world, 8 countries in Southeast Asia region, and many countries in Africa have adopted many of the courses, particularly courses on hypertension and diabetes. So the question coming back to mental health, I think we already have the MHGAP, we have these guidelines, and so it can be easily incorporated into a modular course and delivered. The question is, who should be the target audience? I think the target audience should include primary care physicians, but also should include nurses and community health workers, because in many parts of the world, as Vikram would say, that community health workers are extremely useful in delivering. So we can design those courses and scale them up and deliver them across India as well as the world. The big elephant in the room is funding. Currently, for the development of this course, we have been negotiating with Rotary International from Canada, who have promised to provide funds. So we'll develop the course next year. But in terms of delivery and scale up, we will require some funding. And I think this is a platform where we could discuss such a thing. Thank you.
Thank you very much, Prabhakar. We then go on to Sudipto, who has been working especially along with non-governmental organizations and realizing that many times the government efforts are completely inadequate in many low and middle income countries, for that matter, even in high income countries. What do you see as the role of civil society in this area, and what has been your experience, positive and perhaps negative?
Well, good morning, Shekhar, and good morning, ladies and gentlemen. Can you hear me? Great, okay. So I think civil society has had a long, fairly distinguished, and very substantial role to play in terms of thinking about issues related to people with severe mental disorders across the world. But since I've had most of my experience and my observations from extremely low resource settings, I'm going to describe what I think are the three most important kind of achievements that civil society has made substantial progress on. The first one is related to issues around delivery of comprehensive, continuous, coordinated care in the community setting for people with schizophrenia, for people with other severe mental disorders. And I think this has been a unique and a very influential body of work that has happened across many countries in low-income settings, where it got increasingly demonstrated that mental health service delivery is more than mental health practitioners. Everybody can contribute. People with no background in mental health can be trained, supervised, work in teams to deliver outcomes that are quite amazing. So in a way, this democratization, this taking out of the treatment of mental health from only mental health care providers and making it many other people's business is, I think, one of the most important contributions that civil society has made from low-income settings. And I think that is now official practice. This whole idea of community-based health workers, I think, is something that has been, to some extent, a great game changer. The second important, I think, achievement has been around issues of inclusion, of human rights, and of participation. Supporting people with mental health problems, with severe mental health problems, their families and local communities to come together and have a voice, a say, and determine what is good for us. I think that has been another very substantial contribution from civil society. And the third one that I'd like to talk about is this whole idea that mental health is more than just symptoms that need to be controlled. These are issues around development, around employment, around inclusion, many of the themes that I think we are reflecting in today's conference. And I think in the last 2 decades, this has picked up steam, obviously in low-income countries, but I also think we are living in a very powerful moment because of technology, access, because the world is globalized. What used to be done in small silos, some small pocket somewhere in the back of the beyond, like when I started, I think this technology has helped connect us, technology has helped bring people together, and has made the community a very vibrant one. So I think we are living at a tipping point where many things can be done, and I was listening in the morning to some of the plans that were being discussed, and I think this is exactly the second generation of challenges, that okay, we have the ability to deliver, we can involve people, but can we change systems which are very resistant to change or do not exist in any shape or form? So I think while there have been achievements, if I look back, it is still premature to say that we moved the needle substantially. We have not. But what I see here today is an example of what we need to do to actually make that effort. And it's a real pleasure to be here and discuss and talk over the next 2 days what we can do. So while I'm very hopeful, I also know that this is going to take a long, long time. Thank you.
With the people on the stage and people in this room, hopefully it will take just long time and not a long, long time. Let's go for that. Ralph, you have been associated with Fountain House for a long time, and you have advocated for and actually worked for holistic care for its members. How would you like to see this model being implemented more widely, outside the Fountain House boundaries, by everybody?
So first of all, thank you, Shekhar, for hosting this panel and for being such a key person in organizing the entire conference. And I also wanted to thank everybody who have worked on these guidelines. In particular, I know there's already been a shout out to George Handren and the Sidney R. Bear Foundation. I wanted to thank them for funding this and kind of giving us the fuel to move this along to where we are today for your wonderful presentation. So to get to your question, I think what we've been discussing at Fountain House for now a number of years is we talk about community. And community for us, obviously, is our building, which you're all going to see tonight, today, when you come to visit us. Community is a place. It's our place. It's a place where we give people with serious mental illness, where they take their place, because it's their clubhouse. As you know, we define it as a clubhouse, and they take their place, and they are accepted for who they are at this moment in their recovery. So community. And as I said, that's our community, but I would like to see this notion of community disseminated around the world, and it can be anywhere. It can be in major cities, and in particular, I'd like to focus on low and middle income countries, because that was what I believe is our moral imperative to assist in providing this sense of community. Not that community doesn't already exist, but I think we can help to underscore community as a starting point for recovery from serious mental illness. And basically what that community means, as I said, is a place. And then all the other connections. Without a doubt, everyone is talking about integrated care. Elinore gave a wonderful presentation on integrated care, and we are big believers in integrated care. But in my experience of almost 30 years, as good as a physician, clinician, mental health professional can be, if the targeted individual, the person with serious mental illness, doesn't have those supports, doesn't have a place to call home, and doesn't have the advocacy that goes with the community, I can't just write a prescription for insulin, and then the person it lives in a food desert where all they have access to is high carb, high sugar foods. I can't just write a prescription for psychotropics when the individual doesn't have a purpose, doesn't have a reason to get up in the morning. Everyone here had a reason to get up in the morning. Many of you very early this morning, but you all had a reason to get up. And I think that's fundamentally what we need to create and to give. And I think clinicians, in particular specialists and all kind of physicians and other healthcare professionals are going to be a part of this. But what goes on in the community, which can be anyone can be part of that community and be an assisting, and as I said, can be disseminated in particular in any kind of situation, whether it be low economic or high economic kind of situation. But ultimately what I would like to see is that. And the last thing I would like to say that community needs to focus on, and I think some of us have touched on this, is the notion of isolation. Isolation kills. And as well as we're doing, I know there are some of our members that will go out and buy a pound of salami and a loaf of bread, and that's their dinner every single night. And we have resources to help, but I don't think we're doing a good enough job. And I think this goes around the world where people are eating alone, where they're living alone, and isolation kills. And I think our community can help. And I know that there's big movements to do that, but that has to be part of what we move forward from this conference.
Very well said, Ralph. Isolation kills, and the community is the answer to remove that. Thank you very much. Elinore, I noticed in your presentation that you said we need to do a much better job. Next time you meet your boss, the Secretary for Health and Human Services, what are you going to ask for you to be able to do a better job?
Nice.
So I'm actually very encouraged by what's happened during my time in this administration, because there is a real interest in people living with mental and substance use disorders. There's no dispute politically in our country around the opioids crisis. Democrats and Republicans work together, and I have to speak politically because, I mean, that's who I am. I'm a political, right? I'm the assistant secretary, and I'm in the federal government, and I work for a Republican president. There is no disputes around what the needs are related to getting care and treatment to people living with these kinds of conditions. There is also increasingly acknowledgement of the issues related to serious mental illness and what we need to be doing to address those issues. These programs that I talked about actually come from previous years when we had President Obama. The certified community behavioral health clinics come from a Congress that was during that presidency and moved forward, and this administration supports that. So I say this because I think it's important to acknowledge that everyone that I've worked with on either side has been willing to hear what the needs are and what we need to do. Having said that, there are not enough resources, and so there's always this kind of push me, pull you around resources, and so those are the kinds of arguments that I have to make as to why we should get more money for particular types of interventions. The first thing that I don't want to spend too much time, but I'll just tell you that I consider my agency, the Substance Abuse and Mental Health Services Administration, really to be a demonstration type agency. We have ideas, we have experts that do a lot of work with the public and stakeholders, and so we come up with different types of programs. If we are fortunate, the administration and Congress will fund them, and that's how we've gotten some of these programs. But we'll never be the agency that funds everything. Who does do that is going to be the Centers for Medicare and Medicaid Services. And so one of the things that someone like me has to do is then go to them and talk about why we should be funding things like Fountain House as part of a bundled system of payments. Why should we move to certain types of payment mechanisms? Why should we provide integrated care services? And then the first thing that I'll be asked after I get that meeting is, what's the evidence for what you're proposing? And so that's where things like the WHO guidelines come in handy, because I can say, look, this is a global issue. Experts internationally, and including people from the United States, have put this together. We also have stakeholder groups that have done a lot of work on bringing together the evidence. I agree there's not enough evidence, but that does come down often to funding issues itself. Doesn't mean that we should not talk about what we see as promising interventions. And so once we can have those discussions, if I can be successful, then we can get insurers to pay for these things as a routine part of care. That's what needs to happen, and that's what will bring us parity. When I talk about parity, I talk about the need for people living with mental and substance use disorders to get the same kind of care without the barriers that if you had a physical health condition, you would be able to get easily. We want the same thing, but we also want our clinicians to be paid at the same rates as our colleagues on the medical side, because if we do that, we can bring people in who will provide that care and services. In that way, we serve the needs of our people who are living with these conditions. So my role is more one of sort of bringing all of this together and then making the case to the secretary, making the case case to my colleagues in other agencies who will be the ones to implement. I think we're making a lot of progress on that. This administration has already put in place 1115 waivers for lifting the IMD exclusion around inpatient treatment of substance use disorders. We're looking at how we can make sure that everybody with those kinds of issues gets an inpatient bed if they need it, but at the same time, it's given me an opportunity to talk about those different levels of care that I have found in my own practice to be lacking. So things like partial hospitals, intensive outpatient treatment, and supported housing, those kinds of resources that are really hard to get, but they make so much sense. It's far less expensive to provide those community services than to put people into hospitals. So that's what we work on, and we all work together, and I, like my colleague here, feel very optimistic and hopeful that we'll make real progress. I think we have already, and I think we'll continue to do that.
Thank you very much, Elinore. We consider you part of this community, and we are with you. So tell us if we can help to strengthen your hands when you go for these plans and better resources. Thank you. Lastly, Tarun, WHO has done very well to develop the guidelines. They have been launched today, but the work is far from over. What are the next steps that WHO is willing to take, especially with the very positive message from the DG of WHO in the video?
Thanks, Shekhar. I think the first step, I would say, is starting with the dissemination of guidelines. And I thank Fountain House for giving WHO the opportunity not only to collaborate, support, but also launch these guidelines in this conference, which is, I think, is the way we should be doing things. But I urge these people who are sitting in these conference venue to disseminate it through your networks. Let everybody know, the healthcare providers, other policymakers, anybody who's a stakeholder, that these guidelines are available. I'm not also so digital media savvy, so I may forget some of those channels, but use your Twitter account, Instagram, Facebook, whatever other digital media to disseminate this further. So maybe there should be we should be looking at the tweets after this conference on how many of you disseminate.
During the conference, it's happening now.
It's happening now. Great. So I'll be looking forward to reading those tweets. But as you said, I think the devil lies in detail, and it is about the adaptation and implementation at country level, and how we can make these things happen. So Prabhakaran, talked about how he can do things in India. I hope these are some of the guidelines that Elinore is going to take up as part of within the integrated care within United States, as well as WHO. I think we have our mental health gap action program. Now, I didn't talk about that in my presentation. So how many of you know MHGAP or mental health gap action program? Wow, impressive, amazing. And how many of you have the MHGAP app on your phones? Okay, this is something that needs to be fixed. Easy, just Google EMHGAP and you can download the app. And I think the reason I mention this, because that's the tool that we have now for the last 10 years for using the primary healthcare services and providers to provide mental health services for priority mental health conditions. So this is a tool that can be used in clinical settings, so the app comes in handy. This is a tool that can be used for pre-service training. This is a tool that can be used for in-service training for all of the healthcare providers, but also for community health workers. So I think that's a powerful tool, and we, in these guidelines, is about integrating these guidelines better into our MHGAP program, and then supporting countries in rolling out. And you heard our DG, and this is the way the new program of work within WHO is focusing on programs and impact at country level. But then comes the other silos, and this is looking at the colleagues who are working in non-communicable diseases. And I don't know how many of you work actually in NCDs. The only person I can see here on the stage is Prabhakaran. But the message here is that as you work in your diabetes or as you work in your cardiovascular disease programs, how do you take better care of people with serious mental illnesses, but also how do you take better care of common mental disorders? Because we know there are associated morbidities and mortalities much more. And this is especially important as we are thinking now, the NCD agenda, which started as 4x4, is now becoming 5x5. Mental health is a component. And so if we want to achieve the targets related to NCD that has been set out, we cannot do without achieving the impact for mental health. And the last thing that I would say is here is about evaluating the impact of these guidelines. So we all know the saying that what doesn't get measured doesn't get done. And I think this is something that WHO brings the expertise on evaluating the impact in terms of the outcomes at the patient level, but also at the health services level, as well as at a policy level. Facilitating the research agenda to addressing the gaps, as Graham talked about. And I want to end by saying one thing, if Shekhar, if you permit me. The discourse for mental health is changing rapidly. We are at a tipping point, as Sudipto said. And I give some examples from this year, starting in May. We had the roundtable on mental health in May. We had the launch of Alliance of Champions for Mental Health and Wellbeing, UK, Canada, Australia. In United Nations General Assembly, there was a side event on mental health, launch of Lancet Commission on Mental Health, the UK Mental Health Summit, a session on mental health in primary healthcare conference, this conference, and I may have forgotten some. I mean, these are the things that have been happening. And I think the discourse has changed, and it is in our hands. The onus is on us, that as we enhance our partnerships and as we enhance our collaboration, that we are able to achieve the change that we are looking for. So the parivartan that Sudipto is working towards, the change that we are all looking towards can happen. And this can only happen if we work in partnership, if we try to break all the silos that are existing. So I'm hoping that with these guidelines, this is one small step towards that big change.
Thank you very much, Tarun, for laying out some of the actions that WHO will do and the need for partnership with all the people here and the wider world. So we now have covered the initial questions to the panel members, and I come back to you in the room. We have the mics on both sides, so you are most welcome to ask questions or to make brief comments. I would say not more than 1 minute each, and I will time it. Can you introduce yourself to begin with and then make the comment? I will take 3 or 4 comments, and then I'll come back to the panel. So please.
First, I want to say thank you for the presentation. I'm Madeline Nagel. I'm at Virusology Nursing at New York University, and I've worked with our WHO Collaborative Center in Geriatric Nursing Education. I had the privilege of serving on our workforce panel at SARSA, which looks at older adults with serious mental illness and the need for services. Which brings me to my point about older adults and serious mental illness. We know people are living longer, not just in the United States, but everywhere, and a significant number of those have serious mental illness. My question is actually Dr. Dua. If you speak a little bit and talk about breaking down silos, since we know that these populations suffer stigma related to ageism as well as serious mental illness. I'm wondering what might be done at WHO to increase the dialogue between aging and life course and mental health.
Thank you. We go on to the next question right here.
Oh, thank you. Can you hear me? I have a comment, and that is, as Dr. Katz was mentioning, there's a myriad of factors that affect the well-being of people with serious mental illness. But I would like to highlight the fact that I believe that stable, affordable, and appropriate housing is by far, I believe, the most important fact, because if you have that element, then you will be able to get integrated care, you'll be able to get exercise, you'll be able to get all of the things that will make somebody with serious mental illness have a fulfilling life. And so right now, it seems to me, and I've had some experience with dealing with this, that while a lot of other services are covered for by Medicaid or various agencies, actual rent for living in community housing is a hodgepodge of funding from different sources is often very hard to find. I'm talking about for long-term housing for the serious mental ill.
Thank you. Can you finish the question, please?
And what I'd like to say is that I would like to see this elevated to the level of a medical necessity, which would mean that rent would actually be covered under Medicaid, for example, because it's something that would prevent or possibly help with dealing with serious mental illness. And my question to Dr. Katz is, I understand that fairly recently you've been able to carve out waivers that let people stay in hospitals who have substance abuse, been able to combat the IMD exclusion. I don't understand why that has not been also applied to people with serious mental illness, unless I'm misinformed about that.
Thank you very much, sir. We take another 2-3 questions, maybe. Yep. Please.
Thank you to the panelists. My name is Javier Vázquez, and I represent Special Olympics International. And my question is for the producers of the guidelines. And if you can tell us if the guidelines are contemplating physical activity based on the evidence of WHO about physical activity and the impact on depression and other mental disorders. We see this in our 5.3 million athletes, of course, with intellectual disabilities, but we know that WHO is now reaching a target, or want to reach a target of reducing 50% of inactivity by 2030. So if you can tell us what is the impact, if physical activity has been included in the guidelines. Thank you.
Thank you. Next question, please, from this side.
Hi, my name is Melody Bellevue. I'm from Southbridge, Mass. Tradewinds Club. And I was thinking when it comes to the financial side of it, as Elinore said, the government can't fund everything. So maybe if the government could do like a dollar-for-dollar match from donations from businesses, maybe we could, for like the first year or two, and then maybe we could get enough businesses to decrease the government funding by having them fund it, because mental health is an issue we all deal with. Every community deals with it. So maybe if we could do something like that, it could cut down on what the government has to pay.
Thank you.
Just a thought.
Thank you very much. The question from that side, please, now.
Hi, my name is Matt Valdespino from Bellevue Clubhouse in Washington State. My question's for Mr. Aquila. We heard in the morning from Professor Sachs about how there's sort of a trust breakdown from medical providers for individuals with mental illness in terms of hearing and their questions being respected. And my question is, how can peer-run communities like clubhouses, what role can they play in helping to create and restore trust between individuals suffering from severe mental illness and the medical providers in both directions?
Thank you very much, sir. And the last question from this side.
Hello, my name is Catherine Ponte of For Like Minds, the first online community dedicated to social peer network dedicated to mental illness. As someone living with severe bipolar I disorder, I think one of the great obstacles and barriers to effective policy and work in the field is that you do not have enough people with serious mental illness at the table. They are not alongside policymakers, they're not with politicians, they're not with clinicians. We're segregated into our own space. It's very difficult for us to integrate and offer our lived experience to inform policies, inform community work that is desperately needed to make it more viable and more relatable to people living with serious mental illness.
Thank you very much for your questions and comments, and I will take the last one. I think this conference is actually setting a very good example. We heard from people with living experience right in the morning in the first session, and we will do so in each of the sessions. So I think it is very important, and this is something that Fountain House does extremely well, and I think we need to learn from that. So my plea to all the people on the stage. I know that many of you are involving people with lived experience already, but if not, do that. And if yes, do that more strongly. I will now pass on to Elinore to begin with for two of the questions that were directed to her, and then to Tarun to answer some of the other questions, and then I'll come back to the rest of you to make 30-second last comments. Elinore, please.
Yes, so the first to do with the IMD exclusion. So the consideration of lifting the IMD exclusion, as you probably know, is related to the opioids emergency in this country. I will just tell you that my own view of that is that while there are some people who will need an inpatient type of resource for dealing with opioid use disorder, it's my own professional opinion that most people do not. That they should be treated in their communities, they should get intensive types of outpatient services and community supports. I think that and other evidence-based treatments, I think that works best for people, but I thought this was important because it's given me the opportunity to say what you're saying, which is, it's really not people with opioid use disorder that need these beds, it's people with serious mental illnesses who don't have the resources. And so that is actually something we are talking about. And I also say this, though, what we don't want to do is simply remove the IMD exclusion and make hospital beds available for the seriously mentally ill, because also most of them do not need to be in a hospital. What they need are different levels of care in communities. And so I have been arguing for funding of these different levels of care and payment models that would provide for those services. I do think that it would be useful to consider lifting that IMD exclusion. I don't know if that will happen. I don't make those decisions, but I feel my job is to advocate for people I've tried to serve for my career, and I think that it's important to do that, but at the same time, I don't want it to be just a hospital bed. I want services within our communities.
Thank you.
And just the lady's comment about the match. I'll just say this, that one of the things that, and I've been working in government for a long time, one of the things that I've seen in this administration that I've not seen previously is the interest in public-private partnerships. And so we actually are talking with philanthropists about the kinds of programs that we're looking to fund in the federal government and what kinds of resources they could bring for some of those resources that we might not be able to pay for, with taxpayer dollars, or that insurers might be reluctant to do, but which we think are really necessary. And so we have private groups that are interested. It's not a dollar for dollar match, but we're hoping that we can set up demonstrations in the country that will show that different types of publicly funded programs can be complemented by private resources and enrich those resources for people that need the services.
Thank you very much, Elinore. Tarun, please.
Yeah. So Graham used the term fatal discrimination, and I would say people in the two end of the life course, children and adolescents, as well as older adults, is fatal discrimination twice. You know, they are, if we are looking at the policies and the frameworks, not much is being done. And I think there are certain initiatives that are happening, and you know, one thing that springs to my mind is that the attention that is happening at globally as well as national level for people living with dementia. So, for example, all member states in 2017 endorsed the action plan on dementia, which is looking at having dementia-specific policies in 75% of countries by 2025. So that's one example. The second, I would say, is the issue of awareness raising and friendliness for people with mental health for older adults. And I think this is something we will be hearing about all the different cities initiative. But as we think about all that is happening, about raising awareness, that how do we take into account the lowest common denominator, people with older adults. And there are some people who say that if we can, for example, have our cities take care of kids and older adults, you can take care of all the other population. The third is the explicit inclusion into our services and the systems model and long-term care models as we think about these older adults. And I think this is something much more action is required. And the last point is about when we are looking at the data, disaggregation by age, and that's extremely important to tell us that whether people with older adults are, accessing these services. And also, I take this opportunity to mention about even the disaggregation of data by gender, because yes, please clap. Yes. Women power. Because it's not only older adults. If we look at people with serious mental illnesses, and if you look at the information, women are also much more discriminated against. And I think there are, again, with optimism, a lot needs to be done in this area.
Thank you very much, Tarun. I've been reminded that we have only 2 more minutes left. So I will give a chance to the other 4 panelists to say something if they want to, in 30 seconds as the concluding remarks, and then we really have to close. So, Graham.
Okay, thank you. I'd like to respond to the comment or the question about physical exercise, and you're quite right, sir. The evidence is emerging quite quickly now that physical exercise can prevent and be a valid treatment for depression. And in my country, for example, primary care practitioners are now beginning to do what's called social prescribing. So maybe instead of drugs, they can prescribe membership of a walking group or going to the gym, which is paid for by the taxpayer. So a couple of closing comments. This is my physical prop, the guidelines. I recommend you have a look at these. If they at all might be useful, please think about taking them up, adapting them to your setting. And maybe like me, you've had the miserable experience of going to a senior policymaker, maybe a minister of health, talking about investment in mental health. And they say, well, we're doing TB, we're doing HIV, we're doing AIDS and infectious diseases, we're doing the killer conditions. Well, we've seen the evidence this morning that it's overwhelmingly now clear that mental illnesses are directly and indirectly killer conditions. So it's time to say to the ministers, with respect, Minister, you're wrong. Mental health problems are killer conditions, and now it's time to invest. And if you are serious about the core element of Sustainable Development Goals, namely leave no one behind, you will now invest.
Thank you, Graham. Thank you very much. Any other concluding comments?
I also wanted to touch base something on physical activity. In terms of behavior change, even for people without mental illness, it's extremely difficult. So it's even harder for people with mental illness. I think in terms of behavior change, WHO or most of us focus on creating awareness. And awareness is not the only thing. We need advocacy. We need people for demand generation. But more importantly, I think we need to provide an enabling environment. I can recall this trial on physical activity in dementia, and it was equivocal and to some extent harmful. So clearly there's need for some research in these areas. And the last point I wanted to make is use technology. We're not using technology. We use augmented reality, we use gaming technology, which may interest people with mental health disorders, and that may be extremely helpful in modifying lifestyles.
Thank you very much.
Wanted to,
Ralph, yes? Your 30 seconds.
Yeah, I was asked a question specifically about medication, people stopping meds, and again, and peer intervention. I would just, again, underscore that in our community, it's hard to distinguish oftentimes between members and staff, but I would say that members oftentimes are the role models, and when people are doing well, I think they can inspire people to understand that medication is just a piece, but an important piece of moving forward in their recovery. And I just wanted to underscore that and answer the gentleman's question. And lastly, housing. And there are examples of government paying for housing, which we could talk offline.
Thank you so much. We come to the close of the session, but not to close of the conversation, which will continue during lunchtime, during the rest of the sessions, and finally tomorrow in the concluding session. So it's my great pleasure to close this, but with big thanks to the panelists, to all of you to be there.